Assalamu alaikum, everyone. Congratulations on the first Autism Spectrum Disorder Conference, and thank you for having me to participate in this prestigious conference. My name is Sidra Kaleem. I am a developmental pediatrician and a pediatric neurologist at AKUH Hospital, Karachi. And today I've been given an interesting topic where I'd be able to discuss what should be the guide, the checkpoints and concerns when we think about medications and diet in autism spectrum disorder. So I have no conflicts of interest, and the objectives of my talk would be for the learner or the attendees to understand that what are the research evidences available to support use or disuse of the pharmacological and non-pharmacological management options. And I think this slide and information in this slide has come up in different presentations, but I think this is something that we have to reinforce because this also guides us towards the management plan. So we know that the male is to female ratio is 4:1. The prevalence of autism is 1 to 2%. That's very common, right? 20 to 30% of the children have epilepsy. 50% have comorbid intellectual disability. There is an unevenness of cognitive profile. Maybe a child is great in one skill but lags severely behind and requires substantial support in another skill. And the recurrence risk is 10%. Now I would focus on the rest of the topic that I have been given, that is the step-by-step management approach. So the reason I use the word management, not treatment, is because there is no treatment. It's not a disease, it's a disorder. There are individuals and children who are like this, and we have to manage certain aspects of their profiles. And the goals of management are to improve the social communicative functioning, to enable a child to communicate, to improve their cognition, and to reduce the impact of repetitive behaviors on learning. By this, I don't mean we want to inhibit repetitive behaviors altogether because they might be the coping mechanism that the child has. We just want to reduce the impact such that it does not affect their learning and their blending into the society. So what are the management options? There are the non-pharmacological options are the early educational and behavioral intervention. And I know some of my colleagues have discussed that in detail, the pharmacological therapy, and then the complementary and alternative medicines. That could be diet, that could be supplements. So before I go into all those type of management options, I'd like to briefly touch upon the way we categorize research evidence. It's just not that we accept all the research that is thrown our way. We have to manage and we have to plan according to the quality of research, how strongly does it guide us towards the management option, and is it actually feasible for us or not. So if it's in a shape of a pyramid, and if I could show you at the base, it's the weakest. So it would be case reports and expert opinion, narrative articles, something that I may write as a blog. A case report is something that I may write for a very rare disease, so that there are just 100 case reports worldwide. Even that would be valuable if I'm treating a rare disorder. Descriptive studies come next. That means there's single subject design. There's somebody I'm following at multiple steps using multiple data points, and it could be or multiple individuals I am seeing at a cross section of time, and just writing the descriptive data. Nothing, no interventions. Then come the pre and post test, or non-randomized, where there is no control of randomization. Above that comes two groups non-randomized, like the cohort study, where a child is exposed and we see them in a longitudinal manner to see what are the effects, and similarly case control, where we go back. On the top is the systematic review and the RCT, the randomized control trials, where there is proper blinding, where there is proper assignment, randomization, and strategies are ensured to have the best possible results. And on top of that are the systematic reviews, where we are actually combining everything that we are getting and drawing conclusions from that. So they are at the top. So while I would be discussing research with you or on the available management options, I would like you to focus on what am I presenting. So what is this evidence supported by case reports or is it supported by systematic reviews? So the non-pharmacological or the early educational and behavior intervention, the most commonly used is the applied behavior analysis, the ABA. And ABA has been tried and tested for children under 4 years of age at the start of intervention. Has been the concept is to reinforce positive behavior and dissuading the negative behaviors. It is suggested and to be used 20 to 40 hours a week. There is limited research evidence, but it doesn't mean that there is no benefit. The consensus of the people or the clinicians who are managing working with children or individuals with autism have actually endorsed ABA as a treatment option, and positive results have been seen in the adaptive communication, socialization, and daily living skills. Then the ASD preschool program, a preschool where there are children who have social and communicative deficit. They are being worked upon by healthcare professionals or allied health professionals, therapists who work on them, and then it is kind of a bridge for them, for parents to learn, to observe, and then practice that at home while at the same time working at their learning needs. There is no research evidence to support, and there is no consensus treatment, something that has not been supported. Then the early start Denver model. It is a model where both the developmental theories and applied behavior analysis are coming together, and that is being delivered by trained therapists and parents. There is a study in toddlers that has shown improvement in cognition. By cognition, I mean intelligence and adaptive behaviors. Then there is More Than Words, the Henin program. It is also used for children under 6 years of age, and it is developed to enhance the social communication between the parents and the children. Although there is limited research evidence, there is a definitive incline towards the use and towards the benefit. Then there is the treatment and education of autistic and communication related handicapped children. This is again a management modality where the parents are equipped and the school is structured in a way where they provide the continuation of the services that they were getting outside. Again, there is limited research evidence and the consensus is towards the benefit. Now you will observe that a lot of these interventions have limited research. It's not that there is no research, it's actually evolving, but the thing is it's much difficult to provide behavioral intervention, to randomize for things and to follow them long term, because there's a lot of patient loss and attrition during these studies. So it's not as straightforward as the other medication related studies are out there. Then the parent mediated or delivered interventions. There are programs to equip or build capacity of parents who can, so that they can understand their child, they can understand why their behavior is stemming from, what can they do, how can they enhance their interaction, and ultimately to work on their overall developmental outcome. It has been shown to improve the parent-child interaction and management of disruptive behavior, but there are mixed research evidence. That means there is positive, there is negative in improving the child's core ASD features. Music therapy is also a new addition to the management modalities, and it has been there for some time now. And there are protocols where using 1 week to 7 months of music therapy has been used. There is evidence to suggest that there are benefits on the social interaction in direct communication and social emotional reciprocity, social adaptation, expression of joy, but not much response to the core features or even the generalizability. So a child may be able to learn the non-verbal communication, but that would be in the music therapy context, might not be able to bring it to their home or into their daily lives. Then something that comes up by parents in questions, use of auditory integration training or other sound therapies, because there is this concept that the children with autism are processing the auditory information differently. But unfortunately, at present, we don't have any research evidence to support the use or suggest that there are benefits. Apologies for these sounds here and there. So for pharmacotherapy, yes, there are medications that are used, but one has to understand the limitations, and one has to understand the indication and what should we be following and how should be documented. So what are the indications? First of all, when the psychological interventions are insufficient, there are safety risks to the child and the safety risk to the caregivers, his teachers, the property, or an impediment to his learning. Secondly, before starting therapy, what should one do is to be clear about the rationale. What are you trying to treat? Are you trying to treat the core features of autism? Are you trying to treat hyperactivity? Are you trying to treat aggression? Then one should be clear about how long would they want to continue this medication. It could just not be that would be for life. There should be points that one has to monitor, how they will modify it. Everything should be clear. That this comes with practice. Then how the treatment should be reviewed and stopped. So what would be the points that would be considered and to just hold the therapy? And if there are any adverse effects, how should one monitor? All of this should be documented. So these are the medications that have been used in children with autism. So antipsychotics, conventional and atypical, stimulants, antidepressants, commonly the SSRIs, alpha-2 agonists like gonfacine and clonidine, anticonvulsants and mood stabilizers like valproic acid and carbamazepine, anti-anxiety and benzodiazepine, and sleep medications. So I'll be touching upon each and every one of them. So first and foremost, the caveat: there is no medication that is proven to be effective in treating the core symptoms. So this is not true. If I would give you a medication to treat autism, it would be completely unfair. I may target irritability, I may target aggression, I may target sleep disturbance, but autism cannot be my target of medications. Secondly, psychotropic medications are the most commonly used for behavioral and emotional regulation issues that children with autism may have. Of that, risperidone and aripiprazole are the only ones that are FDA approved for irritability in children with autism and in children and adolescents with autism. SSRIs are poorly tolerated, unlike children who do not have autism, but have been used for restrictive repetitive behaviors, anxiety, and depression. Buspirone is something that is evolving. The literature is evolving for restrictive repetitive behavior, something to think about when managing a child. So this was an amazing algorithm that I came up, and it was in Indian Journal of Psychiatry, and this was their guidelines for autism, and where I'll take you step by step. So you start with the target symptom domain. So what are you actually targeting? Is it irritability? Is it hyperactivity in attention, or the repetitive interest or activities? So while managing irritability, you have to keep in mind, are you dealing with a child who is prepubertal or postpubertal? In a prepubertal child, if the symptoms are mild, one can go for alpha-2 agonist, like clonidine, that is available. We don't have gonfacine in Pakistan. If it is ineffective, we can give a trial of atypical antipsychotic. If there are severe symptoms, the self-injurious behavior, injuring caregivers, teachers, or damaging property, one can directly go to atypical antipsychotics. If there's a failed trial of one atypical antipsychotic, one can actually try another atypical antipsychotics. If there is a failure of that as well, one can actually go for a trial of mood stabilizer. For postpubertal children, one should start with atypical antipsychotics. Alpha-2 agonists are not very effective. And again, if the trial of one fails, one can go for the other one. And then if it again fails, one can choose a mood stabilizer. If we are working with children with hyperactivity and inattention, alpha-2 agonists are better tolerated than stimulants. One has to remember children with autism do not respond well to stimulant medication. If that alpha-2 agonist has been ineffective, one can give a trial of atmoxetine. If a child fails even that, a low dose of stimulant can be given. And even if that fails, one can go again to the atypical antipsychotics here. For the repetitive interest and activities, SSRIs, and if a child fails one SSRI, we can give a trial of another. Also, we can use buspirone. So now I'll be discussing each of the medication in some detail. So for risperidone, an older atypical antipsychotic, has been extensively studied for children with and without autism with emotional regulation problems, aggressive behavior, and irritability. There are 2 trials of risperidone in children with autism, and it has been shown to improve and support in terms of behavior improvement when compared to placebo. So placebo is like something that has no clinical impact. But one has to remember the adverse effects while prescribing, and keeping an eye on this is of great importance. So sedation, increased appetite, weight gain, elevated prolactin levels that can actually cause lactation and breast development. Movement disorders, hyperglycemia, that means sugar regulation problems, and hyperlipidemia, increased cholesterol, poor lipid profile. The way it is being dosed is for children less than 44 pounds, 0.25 milligrams per day, and for children weighing more than 44 pounds, 0.5 milligrams per day. And one can go to from 0.5 milligrams to 3 milligrams per day. Then aripiprazole. So it's a newer kind of atypical antipsychotic. It has been shown to improve irritability and decrease stereotypy in children and adolescents. The rates of movement disorders are a bit higher when compared to risperidone, but the safety profile in terms of the metabolic side effect that we discussed, like hyperlipidemia, weight gain, that prolactin differences, that are much better in our aripiprazole, and this is available. SSRIs, the selective serotonin reuptake inhibitors, that is commonly prescribed for adolescent and adults for depression and anxiety, have also been used in children with and adolescents with autism. This should be used in children who are failing to respond to structural environmental changes or therapies. The evidence is sparse and is not of the equal quality as for typical children, and one has to make the decision on case-to-case basis. Methylphenidate, the stimulant, or Ritalin, or Concerta by Fenton, that is available in different countries. It is used in children with hyperactivity who are not responding to the behavioral intervention. That is hyperactivity that is impacting their learning or causing children to have difficulties at home or at school. Unlike children without autism, children with autism actually have limited response. Only 30% of children respond to methylphenidate. And once you start methylphenidate, weight and BP monitoring should be done. There is appetite suppression, there is weight loss, and long-term studies on children with ADHD have shown even in decrease in height. Also, before starting, ECG should be done to rule out cardiac arrhythmias. Melatonin. Melatonin is a hormone that we secrete, the pituitary gland, and that helps in sleep. And there are 65 studies actually on sleep disturbances in children with autism. And the prevalence, when it was combined, the prevalence was around 64 to 93%. So one can expect a child with sleep disturbance, having poor learning, having behavioral issues, may have difficulty in adjusting. So treatment with melatonin has actually seemed to improve the sleep disturbances, and it actually affects the overall quality. So the sleep latency, that is the time from going to bed and falling asleep, then the sleep duration throughout, the nocturnal and early morning awakenings. It has been effective in all aspects of sleep. Also, it has been shown to cause improvement in typical autistic behaviors in children. The doses are from 0.75 to as high as 15 milligrams. But what other studies suggest that after 9 milligram, one has to look for other options like benzodiazepines or antihistamines. But the sleep quality for those medications is poor. The duration of use has been from 14 days to even 4 years in regulation of sleep cycle. The adverse side effects are daytime sleepiness, dizziness, stomach cramps, and irritability. Alpha agonists, like as I mentioned, clonidine and guanfacine, the evidence is emerging. So it is being used for ADHD, it is being used for behavioral disturbances, but it's not enough to be put in recommendations. But as I said, it's an ongoing process. So now coming up to the complementary and alternative medicines. This was a systematic review with 19 randomized controlled trials, and I just love this slide because it combines multiple nutritional and dietary interventions in one place. So there were 19 RCTs, out of which 4 had low risk of bias. That means a good quality study. Of total, there were 732 patients. This was published in 2017. This actually showed that omega-3 supplementation did not affect the challenging behaviors and was associated with minimal harms. But the strength of evidence was low. There were 2 RCTs of different digestive enzymes, like secretin, that has been used, but there is insufficient strength of evidence, and then it can cause harm to the patient. So that is something to be cautious about. Then there were studies on supplements like methyl B12 and levocarnitine, some improvement in symptom severity, but there is again an insufficient strength of evidence. For use of vitamin B6 and magnesium, that is again a common parent question, there is no evidence. For studies that are evaluating gluten and casein-free diet for children with autism who do not have celiac disease. So let me stop here. For celiac disease is a gluten hypersensitivity for which the treatment is gluten-free diet. But then, and celiac disease may have a presentation of autism, but that doesn't mean every child with autism will have celiac disease. So gluten-free diet again has insufficient strength of evidence. And there were no effects on behavior or GI symptoms with challenge foods. There have been also RCTs on camel milk. There is also an insufficient strength of evidence. Another question that comes up is about a particular dietary plan using virgin oil or olive oil using inulin. Unfortunately, there is no research evidence. Maybe it will come later, but at present, we cannot recommend this as a treatment option for autism. If one may want to switch to olive oil for healthy living, that is a choice that they can make, but it would not have an impact on autism's core symptoms of autism spectrum disorder. Then another question, that would chelating agents be helpful, like assuming that the child has toxin that have to be removed. So there is no evidence of benefits, and there have been studies that showed that oral DMSA was used for up to 6 months for children with ASD who were shown to excrete high levels of heavy metals, but no benefits were found. Then hyperbaric oxygen, assuming that the child may have had low oxygen, high oxygen demand, and providing hyperbaric oxygen will result in improvement. but there is one RCT that has shown no benefits. Uh, Again, the use of probiotics and prebiotics. Yes, this is an ongoing discussion that children with autism do have bowel disturbances, and would providing prebiotics and probiotic change their cognitive and behavioral outcomes. But there is not a lot of evidence, and even the results are controversial. So this was a systematic review that was published in 2019, where they showed that the early administration of probiotics could have a preventative role. However, this is just one systematic review. Acupuncture, something that is being offered in West. We have our own version, Hajama. No studies on Hajama, but few on acupuncture. And there was an intervention designed with 4 weeks or to 9 months of manual or electrical acupuncture versus no treatment. And well, the results were to suggest a better language comprehension cognition. However, the quality of study was very poor. So one has to actually see what kind of study that was. So these are my references, and I know I have led to a lot of questions and discussion, and I would be happy to take your questions. Thank you.